The most common causes of cardiac arrest. Common potentially reversible causes of cardiac arrest can be summarized as the 4HS and the 4TS. Hypoxia. Treat hypoxia by ensuring the airway is patent. Ventilate the lungs using high-flow oxygen. Although it has been common practice to hyperventilate a patient in cardiac arrest based on the premise that this will help to reduce any hypercarbia, this practice should be avoided as hyperventilation reduces coronary perfusion pressure and worsens outcome. Hypovolemia. The cause of hypovolemia may be obvious, example blood loss or severe diarrhea, or more subtle, example severe sepsis or anaphylaxis. If hypovolemia is suspected, rapidly infuse intravenous fluids. Hypokalemia. Near-patient testing equipment allows the rapid measurement of potassium and glucose. Review the patient's latest laboratory results. Immediate treatment of hypokalemia requires administration of calcium chloride followed by insulin dextrose infusion. Low potassium magnesium levels may be treated with an infusion of a solution containing the deficient substance. Hypothermia. Hypothermia is rare as a cause of in-hospital cardiac arrest. Measure core temperature with a low-reading thermometer. Use active rewarming techniques to treat a hypothermic patient in cardiac arrest. Cardiopulmonary bypass may be considered if facilities are immediately available and active rewarming strategies fail. Thrombosis. Coronary thrombosis is a common cause of cardiac arrest. If an ACS is suspected as the cause of refractory cardiac arrest, it may be feasible to perform percutaneous coronary angiography and percutaneous coronary intervention during ongoing CPR. This would require the use of an automated CPR device and/or extracorporeal CPR to maintain circulation during the procedure. Another common cause of thromboembolic cardiac arrest is massive pulmonary embolism. If this is thought to be the cause of cardiac arrest, consider giving a fibrinolytic drug immediately. Survival and good neurological outcome have been reported in cases requiring prolonged CPR. Consider performing CPR for at least 60 to 90 minutes in this setting. Tamponade. Cardiac tamponade is difficult to diagnose without focused cardiac ultrasound, as many of the features on clinical examination are difficult or impossible to elicit during cardiac arrest. Tamponade should be considered after penetrating chest trauma or after cardiac surgery, device implantation, e.g. pacemaker, and percutaneous coronary intervention. Treatment is with either needle pericardiocentesis or resuscitative thoracotomy. Toxins. Drug toxicity is a relatively unlikely cause of cardiac arrest unless there is evidence of deliberate overdose or suspicion of substance abuse. For inpatients, a review of the patient's drug chart may be helpful. Tension pneumothorax. In an intubated patient, check the tube position, as intubation of the right main bronchus can further complicate a tension pneumothorax, which can be difficult to diagnose during cardiac arrest. It may be indicated by unilateral expansion of the chest, shift of the trachea, or subcutaneous emphysema. Pleural ultrasound in skilled hands is faster and more sensitive than chest X-ray for the detection of pneumothorax. Early needle decompression, thoracocentesis, followed by chest drain insertion is needed. Needle decompression may fail if the needle used is too short. In a ventilated patient, thoracostomy, a surgical hole in the chest wall and pleura, may be quicker to perform and more effective in releasing the tension.